Thank you, everyone, for joining us for the first Office of Rural Health webinar in our series. We appreciate you signing in. My name is Kristen Wing. I'm with the Office of Rural Health Communications team, and I'm here to introduce you to our moderator and our presenter today. But before I do that, I'm going to go over just a few housekeeping issues. The webinar is set for lecture mode, so everyone's phone will be muted until the end of the session. If you do have any questions as information is presented, please feel free to use the live meeting question and answer function, and as appropriate, they will be addressed during the presentation. Most questions will be saved and addressed at the end. Following this presentation, it will be made available on the Office of Rural Health website, and we'll follow up with the link to that presentation in an email probably sometime later next week. I'd like to go ahead and introduce our moderator. Dr. Peter Caboli is the director of the Veterans Rural Health Resource Center Central Region located in Iowa City. Dr. Caboli is a core investigator also with the Comprehensive Access and Delivery Research and Evaluation Center, also known as CADRE, and an associate professor of internal medicine in the Division of General Internal Medicine at the University of Iowa. Dr. Caboli is a former VA Health Services Research and Development Research Career Development Award recipient and a VA Quality Scholar Fellowship alumni. His research includes rural health, inpatient medical care quality, organization, development of valid methods for measuring appropriateness of medication prescribing, and to develop interventions to optimize medication delivery and effectiveness to vulnerable veteran populations. Thank you, Dr. Caboli, for being our moderator today, and I'll turn it over to you to introduce our presenter.
Thank you, Lindsay, and thanks everyone for calling in. This is, as Lindsay said, the first in a series of webinars hosted by the Office of Rural Health, and it's good to finally get some interesting things out there. So as a quick background about the Rural Health Resource Centers, one of our goals is to identify areas of concern or access disparities for rural veterans, and then come up with a design or implement new strategies to overcome this observed disparity. So in the case that we're going to talk about today, Bonnie Wakefield, who will talk more about herself, but she's both a VA nurse and has a PhD in research and is a telehealth researcher. She's been in the VA for quite a while and is known about this problem about cardiac rehab for rural veterans. This has been especially true or problematic in our area in Iowa City, where we do not offer cardiac rehab, and in fact most VA hospitals do not offer cardiac rehab. And the other contextual problem here is that we have a Project Hero contract for cardiac rehab, but there are no hospitals within the contract that are in the state of Iowa. So for our rural veterans, it's even harder because they would have to leave the state to do cardiac rehab, which is more problematic. So Bonnie identified an area of concern, an area where there was an access disparity, and came up with a solution using telehealth and using the concept of bringing care closer to the veteran, in this case bringing the care into the veteran's home. And I can tell you when she first brought up this idea, I was a little skeptical, and not because it wasn't a good idea, but I was skeptical about cardiac rehab in general. And over the last 2 years, I have become a true believer. So she has converted me to the benefits of cardiac rehab. So I will turn it over to Bonnie because she's the one with the interesting information.
Okay, thanks, Peter. Can you all hear me okay? I'll take that as a yes. So as Peter said, I'm going to talk today about our project focused on the remote delivery of cardiac rehab. He has already introduced me. The next two names you see on the slide, Carrie Ann and Melody, throughout this presentation, when I say we, I really mean Carrie Ann and Melody, because they really delivered the program, kept all the trains on time, took care of the patients, troubleshooted everything. So they deserve a lot of the credit for this project. Tom Klobuchar, who used to be in Iowa City, who's now in the Office of Rural Health, assisted with the cost analysis, which I'll talk about a little bit later. Skylar did our data analysis for us, and of course Peter answered all those doctor questions, cheerleading from the side, and other duties as assigned, I guess. So the literature notes that cardiac rehab provides significant benefit for people with cardiovascular disease, but as Peter noted in the introduction, geographic access to on-site programs is a problem in the VA, and particularly in the state of Iowa. And I have been in the VA for a long time. I actually started in the VA in 1983, so this problem's been bugging me since 1983, and I finally had an opportunity to do something to address the fact that there aren't any cardiac rehab services conveniently available for veterans. So the purpose of our study, our project, was to test the feasibility and safety of a Phase 2 outpatient remote cardiac rehab program. We collected data on clinical outcomes. So I'll give you a list of those later. Patient and provider acceptance and uptake. So would patients really do this? What would the physicians think? Any safety issues with having people, in the home as opposed to, on a monitor, typically within a hospital setting. And then, of course, we wanted to know how much it costs compared to what we're already paying for fee-basis cardiac rehab. So the people we included, we wanted to look at, let me back up. We wanted to exclude, high-risk patients. So people we chose to include were people with an acute MI or ACS, post-cardiac surgery, PCI interventions, or they had stable angina. They had to be age 18 or older to participate, English speaking primarily because Carrie Ann and Melody speak English, and of course medically cleared by cardiology to participate in the program. So we had a much longer list of exclusion criteria, and the first two-thirds of these criteria identified patients that we felt were just too high risk for us to be recommending that they are exercising in the home without sort of direct hands-on supervision. So you can see, people with very low ejection fractions, blood pressure that's out of control, or other, sort of medical illnesses that might preclude participation in a program like this. We excluded CABG surgery redos because we felt that, if patients had continued sort of their bad habits after their first open heart surgery, delivering the program the second time was probably not going to be cost effective or, that helpful. And then, of course, the last two we excluded because you have to be cognitively intact to participate in the program. And then anyone who was terminally ill, of course, would probably not want to participate. So how this happened is that every day, Carrie Ann and Melody screened inpatient admissions for potential patients. So looking for someone who came in for a rule-out MI or heart failure, post-CABG surgery. We also looked at patients in the cath lab and the cardiology clinic, so really established some relationships with people, in those two settings to identify patients that might sort of fit the bill and want to enroll in this program. Prior to approaching patients, we talked to the physicians about the suitability of patients. So we didn't want to talk to the patient first and then find out later that the physicians, felt like this person wouldn't be an appropriate candidate. When the patients were approached, they were given a choice to attend either the remote program or the face-to-face program. So we approached them while they were in the hospital or at the hospital, at cardiology clinic for enrollment. If they preferred the local program or the fee-basis program, we then send a referral to the VA staff who typically arrange that enrollment for the local face-to-face program. And then physicians entered a consult in CPRS authorizing cardiac rehab. So what we delivered was based on a Phase 2 cardiac rehab program endorsed by the American Heart Association. We used an American Heart Association workbook and DVD called An Active Partnership for the Health of Your Heart. We also developed a patient workbook, and that included logs for recording exercise, food diaries, written instructions for the equipment that we gave them, and some written materials to supplement the active partnership book. People were given an individualized exercise prescription. Carrie Ann is an exercise physiologist, so she knows how to do this. They were typically asked to exercise 3 times a week for at least 30 minutes. So, walking, if they had a space to walk, and we asked questions at enrollment about where they would have access to walking, could they go to the mall? We also, I'll get to this in the next slide, we gave them a pedaler. So it's basically, 2 pedals that you can sit in a chair and pedal on, or you can put it on the table and exercise using your upper arms. Let's say if you had a lower extremity amputation and couldn't use it on the floor, so that would give you some aerobic exercise. So as I alluded to in the prior slide, we gave participants the portable exercise pedaler, a pedometer, a heart rate monitor, and a blood pressure cuff. And they were instructed on how to use each of these pieces of equipment. And as I said earlier, we also gave them some written instructions in their workbook, so once they got home, they still had instructions in case they'd forgotten something. Participants were also instructed how to contact their local emergency medical system in the event of chest pain or an emergency. So we had to make it really clear that if they were at home, exercising or whatever, and they started having chest pains, they were not to call us. They were to use the regular system, in their local community for how they would get emergency help. Once they were enrolled, they received a weekly scheduled phone call visit with the study staff for 12 weeks. And so we have a curriculum of topics that were reviewed each week via a phone call. And the phone calls lasted varying amounts of time depending on, how many questions the patient had and what the topic of the week was. And that was scheduled. So it was like a scheduled appointment. Let's say, noon on Wednesdays for 12 weeks. Of the patients we screened, using our inclusion-exclusion criteria and physician, review and approval of patients, in over 1 year we had 107 eligible patients. Of those, 45 refused participation in either program. They just weren't interested in cardiac rehab. And of the 62 that agreed to participate, the majority chose the home-based program, 48, and then 14 chose to go to a local program. Overall, the mean age of this group was 64 years. They are almost 100% were Caucasian, male, and with a high school education, and then 2/3 of them were married, so they had someone in the home with them. The reasons people got referred to this program are listed here. Most were post-PCI or stent placement, 18 had stable angina, 9 with an MI or acute coronary syndrome, 7 post-CABG, and then 3 that had some other type of coronary artery disease that fit with the cardiac rehab program. These are the outcomes we measured, most of these both at baseline and at 12 weeks, and we measured these in both the remote group and then the 14 patients who all went to the local program. So we took their blood pressure and heart rate, a cholesterol panel, and we didn't do an extra lab test for the project. We just used what was already in their record. Height and weight to calculate a body mass index. We had a 4-question instrument that addressed medication adherence. We used the geriatric depression scale both at baseline and 12 weeks because depression is quite common in post-MI patients. The Seattle Angina Questionnaire, and it has 5 scales within it, and that is a well-known tool to measure quality of life in cardiac patients. And then we measured knowledge about coronary disease using a test that has been published. And then at the conclusion of the program, we measured satisfaction in patients who attended the remote program, and then we did a cost analysis. So what did we find? We found there were no significant changes over time between the groups at 12 weeks in any of those outcomes, rates of rehospitalization, or ER visits. The remote participants had a high completion rate. They attended 89% of scheduled sessions. So what that means is in the patients who chose that program, we multiplied that times 12 sessions and determined how many of those they attended. The face-to-face program participants, or the fee-basis patients, completed 73% of authorized visits. And we were able to get that data because when we got the cost data, the VA pays per session. So they might authorize 12 to 24 sessions, but they have to be documented that they attended the session. So we know that that's an accurate number. Now, of those 14 patients, one ultimately did not attend any cardiac rehab program because it was too far from home for him to drive. So the face-to-face participants, we estimated, traveled on average 15 miles round trip to attend on-site programs, and that ranged from 3 to 36 miles. Now remember, they're traveling, typically once or twice a week because some programs have two times per week sessions. So they were logging quite a few miles. At the conclusion of the program, we measured satisfaction of the remote participants. And these were the questions that we asked them. And you can see on a 1 to 5 scale, where 5 is strongly agree, that this group of participants was very positive about the program. They felt the information they were given was helpful. The education given them before the program was helpful. The highest score was completing the program at home was convenient. They felt the people who guided the program were helpful, had a good understanding of their condition, and would be highly likely to recommend it to other veterans who might need this. As I said, we also estimated costs. So I'm going to kind of walk you through this table. So in the second line there, the contract cost per patient. So we were able to get the fee basis information for what the Iowa City VA paid for cardiac rehab. So those are actual mean costs per patient referred in that year that we were doing the program. So it stays constant. So then under the remote delivery cost per patient, we estimated the cost of delivering the program remotely. So we knew how much the materials cost. We used the GS9 salary therapist for personnel costs. And then we estimated, we knew those costs, but then we estimated about how much time it took, to enroll patients and deliver the program, and do the data collection. So you can see that having 48 patients in a year, the absolute difference is about $88 more per patient when you have about 48 patients per year. And in large part, that's because you take one salary and spread it over 62 patients. So then we looked at if you had 100 patients per year, so you still have the same fixed cost of materials per patient and about the time commitment, but then you take the salary and it spreads out over 100 patients. So that made, which is probably a reasonable workload as well, so that made the remote program about $350 per patient cheaper. So we were happy to see that. So in conclusion, the remote participants remained engaged in the program, and the outcomes were comparable between groups. Now, of course, we would have liked to have seen the remote program patients have better outcomes, but the nice thing is they didn't do worse, and there were no adverse events in the remote participants, no calls to EMS. The dropout rate was low, so in the remote group, we started with 48, 5 dropped out, and in the face-to-face group, we started with 14, 1 person never attended, and 1 patient died unrelated, to his cardiac rehab. So we felt that the retention rate was actually pretty good in the remote group as well. So we concluded that home-based cardiac rehab is not only safe and effective, but brings services closer to the patient and their home, which is fundamental in caring for rural veterans. So now you can open it up for questions, or if you have questions, Peter, that people have sent in, I'd be happy to answer those. Carrie Ann, if you are off mute, I don't know if you have any other comments to add.
Yes, I'm here. I think that the program went really well, and I'm excited about where it can go from here.
So one of the things that wasn't in the presentation that Carrie Ann has shared with me is that in scheduling these calls, and a somewhat common reason for people choosing the remote program is many of these veterans were still employed. So they could do this, on their lunch hour, like schedule the call at noon or after work, where if they had to attend the fee-basis program and travel to it, in the morning or afternoon during the work week, they would have to miss work, once or twice a week for 12 weeks, and that just wasn't feasible for them. So this also, I think you could call it sort of a patient-centered approach, because it really fit into the lifestyle of the patient. The other untested but theory of mine is that if patients go to, a local program, so they go to the hospital for 12 weeks and do exercises, I think there's the issue that once they're through the 12 weeks, they think, okay, I'm cured, and don't really integrate this into their lifestyle, where if you're getting it in the home and exercising in the home and sort of building this into your daily routine in terms of, making a walking plan or using the peddler, that you might be more likely to continue that once the program is over, because you've already learned how to integrate it into your lifestyle instead of, driving somewhere to do it. So I can't, say that happens, but it seems logical to me.
I know Bonnie mentioned this before, but a lot of patients sometimes have to go to cardiac rehab even 3 times a week, most generally 2 or 3 times. So I think that the program really gave them another option, and instead of having to travel a distance, be there for an hour time period, and then travel back. Also, cardiac rehab just isn't about exercise. Like she said, we had lectures. We talked about nutrition.
So I was going to ask for another question, how when they approach physicians, any options from what the physicians had to say about the program?
I'm here. I think that the physicians were really another option. I think that they were really careful on who they recommended, and really went with our criteria. That they gave patients another option that might not get cardiac rehab, might refuse it because of distance or jobs or just not wanting to attend a traditional program.
Right. So they carefully considered, the likelihood that the patient wouldn't have some kind of adverse event at home. So I think that was another sort of check on our inclusion-exclusion criteria, that, having the physician who knew the patient take a look at that as well. But in general, they were, open to referring patients who were appropriate for the program. So I think that says a lot as well.
Yeah, and I can add in a comment as one of the potential referring physicians, and that is anything like this that can be done that lowers any barriers for providers it makes it much easier for us to do. In talking to the people in cardiology here, one of the problems with getting patients into cardiac rehab was the need to put in the consult. It would go to the community health service people, who then would contact the contractor. That would sometimes take weeks before the contractor would get back as to where they could do the rehab. Then they would have to go to the patient and say, well, can you do the rehab in Moline, Illinois? If the patient said no, then they'd have to do a local fee basis referral. And so that whole thing takes time, and anything that takes time and has a barrier is less likely to happen. But what was nice about this was that by proactively identifying the patients, either hospitalized patients, clinic patients, or post-cath patients, Gary Ann was able to identify the patient and then come to the provider and say, is this patient appropriate for cardiac rehab? And all they have to do is say yes.
And enter a consult.
Enter a consult, but that's pretty easy. Once you know that somebody's going to do something with it, yes.
And I think that's an important point, Peter, because the fee basis program, there are these delays in getting the patient enrolled, especially in places like Iowa where we don't have the contract provider, doesn't have any programs. But you still have to go through the process of them telling you that, even though we know it's true. So the patients get delayed sometimes a couple of months, and also some of the people in cardiology, like in the cath lab and things, or the cardiology nurse care managers, then they keep getting sort of phone calls to follow up on it, to try to get this patient enrolled. And so our patients who were in the remote program, if they were discharged this week, they could start, if they had been trained and so forth in the hospital, they could start right away next week. And so it was much more efficient process as well.
This is Jennifer Six from the Silver City CBOC in Silver City, New Mexico.
Mm-hmm.
I do have a question. I feel like I missed something in terms of what our positive outcomes were from this. Am I understanding that what you're saying is that regardless of whether they went to fee-based rehab or did the remote rehab through you, the outcomes were essentially comparable? But my question is, how much benefit did they get from either program in terms of some of the harder numbers there, cholesterol and blood pressure, heart rate, anginal scale, those things?
I don't have those numbers on top of my head. They did improve in some of those. It's just that both groups improved. For example, on depression, the scale is 15 points. They started out on a mean of 6 point something and dropped down to 3 point something, but both groups dropped. So, there was some improvement in some of the parameters, it's just that there weren't differences between the groups.
Thank you. That clarifies it.
Yeah, and I'll add one other thing in terms of looking at the numbers, because I think that's a very good question. Within VA, if you look at lipids and blood pressure control in terms of at or near goal, most clinics do a phenomenal job. Well above national averages. So blood pressure control rates in the 65 to 70% range, and similarly comparable lipids to target. So that when that happens, you basically have a population that's hard to make much better. And so one of the concerns in doing this project, or why we were studying it, was whether there was a potential for harm. And that came up very early on, and looking at, how many people have cardiac events in hospital-based cardiac rehab? And it's actually incredibly small, even though it's a high-risk population. So we wanted to sort of prove that at least it's as safe, and that we aren't making things worse.
and it's potentially less costly, so you have similar outcomes for a lower cost, and this is just a personal bias of mine, the program stays within the VA, so you can monitor the quality of what the patient is getting as opposed to, and I'm not, in any way disrespecting, community-based cardiac rehab programs, but, when you keep it in-house, you have a little more control over what happens in it.
Well, I think it also strengthens the bond to the VA provider. So I think it's a good thing from that standpoint as well.
Thank you.
Yeah, and to add to that, a lot of these people would have not gotten cardiac rehab at all. And so I think in a perfect world, and Bonnie and I talked about this at the very beginning, if we had unlimited time and money, we would have done this as a randomized trial where patients are randomized to one of 3 or 4 different arms, and we had 1,000 patients in the trial and followed them over 2 years. But that was not going to happen. And, we identified that there was, or Bonnie identified that there was a need and came up with this as an alternative. And so by doing it within the existing system, you get people care that might not otherwise have gotten it.
And that's another good point, Peter, because I know of one other location in the VA where they've tried a remote program and could not get the providers, to do referrals. And so that's one of the things we're looking at now is how do you, to implement this program. Physicians have a lot of things to think about when they have inpatients, and so this is one other thing. So how can we, design a system where they're, reminded to make the referral, or they just have to do one thing to make the referral, and then everything else is taken care of. So how do we make it as easy as possible to refer patients? Because it's, I think, and selling it to the physicians, having this data to say, we enrolled these patients, they did just as well as going to a local program, they attended more sessions, and we didn't have any significant safety events. So when you have that kind of data, physicians, I think, are much more willing to engage in, well, how can we make this kind of part of routine practice?
This is Jim Lund. I'm a physical therapist at VA Montana, and we have a cardiac rehab program that's been here for about 3 years now. Bonnie, I think this is really exciting what you're doing. I'm curious. Unfortunately, I got to walk in today, and so I didn't get on the call until about 12:15. Are your slides available, or was this talk recorded so I could get a little more information?
Yes, we're going to post them. Kristen, do you want to?
Yes. Hi, Jim. This presentation with the audio and the automation with captions will be posted to the ORH website next week. And since you have registered for this webinar, we'll be following up with you in an email and providing you that link.
Bonnie, I wanted to ask, I'm in Montana, so we're maybe even more rural than Iowa. I don't know. One thing that we've done, our system currently is that we do have in-house cardiac rehab at our healthcare center, but we're in a smaller community of only about 65,000 people. So most veterans are referred out to community-based programs throughout the state. And you were talking about having a system that was easy for providers. What we have done, 2 parts. One is that we only have one consult. For all cardiac rehab requests, they simply submit a cardiac rehab consult anywhere in the state, and then our cardiac rehab program will take care of that. So the providers don't have to worry about, figuring out the fee basis or which consult to do. The other thing we started doing is a telehealth visit at a CVOC where we could meet with the veteran and try to smooth that process out in the referral and make sure that they were being covered that way. I think what you have to offer would be a great resource in Montana, though, as well.
Yeah, those are good ideas. Thanks.
Dr. Wakefield, Dr. Kaboli, can you talk about the future of this project, if you expand it into other areas, or some points for folks who may want to try this in their own facility, how they should go about that?
We have had some discussions with our cardiology staff. They're very supportive of this program, in part because of the multiple sort of contacts and phone calls they get in trying to get a patient into a cardiac rehab program, and I think looking at the outcomes, they're sold on this. So that is one of the, we're looking at a couple of things, of course, funding it, and then, again, kind of working out the processes for getting referrals and getting them handled efficiently. I don't know, Peter, if you want to say more about that.
Yeah, Kristen, that was exactly where I thought we should go next with this, because I want to get some feedback from the people on the call about their thoughts. So we're working on it locally, but as you can imagine, and anybody, because we're all in the VA, knows that in terms of incorporating anything new into a current system, either needs to be cost neutral or FTE neutral in some way. So what we're doing is we're actually meeting next week to talk about, the amount of fee basis that we're doing, in cardiac rehab, and using that as the justification. Now, fortunately, we're going to be able to, I think, transition using some funding, partial funding by the Office of Rural Health, to fund the position for one additional year and to get it up and running here. Because we've already done it. Terry Ann already knows the system. She already knows all the people here. The people here are very familiar with it. And so for us here, the barrier to entry to do this has got to be much lower than any place else. So what I want to know is if we wanted to implement this, or facilitate the implementation elsewhere, what would other places need from us to help them do this?
Right. So there's a potential for kind of a hub and spoke program within a VISN. So there are, other, I would assume, similar, like in Montana and, some of the western states, other facilities in our VISN who also, do not have local programs at the VA and, have the same sort of fee basis issues in terms of referrals that we have. So there is a kind of an economy of scale if you could have someone, or someone's handle more than one facility with this kind of approach.
We do have one question that was submitted through the live meeting Q&A. Dr. Caboli, would you like to go ahead and read that?
How do you determine the intensity level of the cardiac rehab program? Do you measure functional capacity level pre- and post-program? My experience in cardiac rehab medication dosage adjustment is rather common due to high or low blood pressure and orthostatic hypotension. So, Carrie Ann, do you want to address the...
Yeah, I can. Yeah, you're right on the point there. Most of our patients are on, beta blockers and things like that are going to affect heart rate. Normally, you would do exercise intensity with finding like a target heart rate range. However, it doesn't necessarily work in this type of situation. We did provide patients with a heart rate monitor to kind of give them an idea of their heart rate. We taught them how to take their, talked about how to take their heart rate, just by checking their pulse on their wrist. A big thing we used was a rating of perceived exertion scale with the Borg scale. How hard do you feel like you're working? Trying to instruct them on a level that was, where they kind of should be when they're working out. And also there's like the talk method. When you're exercising, can you still tell somebody a sentence? So.
But in general, you did not contact physicians about medication adjustment.
No, not at all. The medications just have an effect on heart rate, so it's kind of hard to find intensity levels. But no, I didn't talk to physicians. We also talked about things like chest pain, shortness of breath, different things like that when they were exercising to look for.
And some patients did report that, but I would, make the assumption that patients who were in local programs had the same experiences, but they weren't to the extent that they needed to call an ambulance.
Any other thoughts or suggestions about what we can do to facilitate spreading this. One of the things that we're going to do is put all the materials online and have them all in a format that can be printed off. I don't know, Carrie Ann, if you want to comment on the materials, the amount of material that you give to the patients and in terms of the size of the booklet.
Yeah, well, we've kind of revamped our materials a little bit recently to make it more, VA-friendly, patient-friendly. The binder is quite large, however, we give it to patients so they can keep it. It's kind of a reference point. It has different sections with anywhere from how to use your equipment to nutrition tips about how to get more fruit or vegetables in your diet, different things like that, different exercises that I've come up with there's picture diagrams of how to do the exercises, and we don't just give it to them to do it. It's just I tell them what exercises to do, and they have another form. Other material stuff that I've gotten, I've developed a manual that you could give to, potentially another VA to hopefully help with implementation of the program.
Quite a few of in our revised manual, quite a few of the, quite a bit of the information in there is from VA-approved programs such as MOVE. And there are suggestions for other programs in the VA that might be appropriate for these patients.
Yeah, some of the materials from like Cranes on Demand, that's the VA-approved educational materials, MOVE, some of the healthy living stuff that they're promoting with the VA.
We have another question that's submitted online. Joyce Cox wants to know what response, if any, are you receiving from outside cardiologists concerning this program?
I have not been contacted by any outside cardiologists. Don't know, Carrie Ann, if anyone called you.
Nope, no outside cardiologists.
Yeah, and I'm not sure, how well this could be adopted outside of VA because of the way that cardiac rehab is reimbursed. I don't know, Bonnie, if this ever come up in your thoughts about, could this be a program, generally through the existing system of reimbursement for telemedicine in the fee-for-service world, could this be something a for-profit hospital or even a not-for-profit hospital that was a private hospital integrate into their system and still for the service?
Yeah, I don't know. I'm not an expert on reimbursement. I know that in the private sector, getting reimbursed for any kind of telemedicine program has been an uphill struggle. So any kind of non-face-to-face interaction, it's challenging to get reimbursed for that. That's, another nice thing about operating inside the VA.
Did anyone else have any questions or comments, even in relation to our first Office of Rural Health webinar series? Any topics that you would like for us to present on in the future, please feel free to go ahead and let us know.
And also, Kristen, Carrie Ann and I, and of course Peter, we're all in Outlook, so if people think of questions afterwards, they should be able to find us pretty easily.
Thank you. We'll make sure that your email addresses are included on the last slide of the presentation as well. Okay. Well, with that, it's time for us to go ahead and wrap up this call. Thank you very much, Dr. Wakefield and her team, and Dr. Caboli for moderating. And thank you for all of our participants for joining us. And we look forward to you coming back and being with us on the next Office of Rural Health webinar. Thank you.